Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. Please submit your questions throughout the webinar via the chat function, and we'll try to get to those towards the end. And certificates for attending today will be available by logging into your account on Friday. Sandy, if you'd like to get started, go right ahead.
Thank you, Kim. I'm Sandra Sundquist-Bowman, as the slide says, and I'm happy to be here to share with you today. My background is as a neonatal clinical nurse specialist, in which I spent about 20 years, and a bedside nurse and clinic and transport nurse and educator prior to that, mostly in the NICU, but my clinical nurse specialist is in parent-child health. Currently, I'm at the University of New Mexico in Albuquerque as the manager of clinical trials operations and help to create protocols and enroll families into various studies, and have been doing that for about 10 years now. So today we're going to talk about protecting the feeding experience of the neonate. Something that we sometimes assume is a very simple thing to feed babies, but turns out that that's not always the case. So our objectives are to discuss the advantages for early direct breastfeeding and management of tube feedings in neonates, to describe potential nutrient loss associated with tube feedings, including macronutrients in human milk critical for infant growth, and to discuss some clinical challenges and remedies with the use of the infant tubing connections. And finally, we'll identify some potential long-term effects of neonatal tube feedings and transition to discharge. So I'd like to start by talking about neonatal outcomes and how those have changed over the years. We've had a lot of technological advances that have led to increased survival of even the most immature infants. You can see a couple of headlines that I grabbed off the internet talking about babies born at 22 weeks surviving, not always in the best of shape. So the focus today is really on improving outcomes, and not only survival, but how can we get the best quality of life in that survival. And this is a graph of neonatal outcomes at 2 years published by the NICHD, and it's part of the outcomes calculator that's available online, with outcomes between 1998 and 2003. And you can see that the death rate is quite high for babies at 22 weeks and even up to 25 weeks. And then neurodevelopmental impairment, almost half at 25 weeks have some neurodevelopmental impairment. But, you know, 2003 was a long time ago, and as far as advances in care of neonates. So that calculation of outcomes was redone not too long ago, was just published in 2021, and includes outcomes between 2006 and 2016. And they found increased survival in most groups, but especially in the 22-week gestation, but no significant change in neurodevelopmental outcomes. But also, that outcome depends on a lot more than gestational age. We can't just say, well, your baby is X gestation, and therefore the outcome is likely to be whatever. But there's a lot more that goes into that, we're finding, as we really look at the care and the outcomes. And one of those things is nutrition. So we know that babies who are born small for gestational age or with intrauterine growth restriction have worse neurodevelopmental outcomes. So it matters both prenatally and postnatally in predicting outcome. One group was talking about the fat and energy intake associated with improved brain volume and development in preterm infants. Another evaluated earlier, more aggressive nutrient supply and feeding regimes, including optimal support of breastfeeding mothers to ensure adequate provision of own mother's milk, appear to improve growth and neurodevelopmental outcomes. And many of these studies are done in extremely preterm infants, but we're beginning to realize that the importance of the unique nutritional needs of late and moderately preterm infants is just as important, and it represents a much bigger population than the extremely low birth weight or extremely preterm infant. So there was an article published in The Lancet in 2016 that summarizes the benefits of breastfeeding. It's a systematic review of several papers that have been published, which it's a good one-stop to get that information. I'm sure that most of you on this call are already well aware of these benefits, but I just put a few up here that they report, like the reduction in mortality due to infectious diseases, less diarrhea or hospitalization for diarrhea, less otitis media during the first 2 years of life, reduction in the incidence of overweight and obesity, again, effects that are seen much later in life, risk reduction for both type 1 and type 2 diabetes, and studies show consistently higher IQ in babies that are breastfed with a relationship to the longer time period of breastfeeding. And there are also benefits to the mother that are summarized in this paper, including a reduction in breast cancer, improved birth spacing, and trends towards a decrease in ovarian cancer and type 2 diabetes. And the act of feeding is an important developmental milestone. That's something that, again, we take for granted many times, but feeding difficulties are associated with worse cognitive and motor outcomes in the first year of life for babies born less than 28 weeks gestation. And some persistent feeding problems that might be seen include feeding refusal, prolonged feeding time, poor acceptance of textured foods or family's diet, coughing or choking, oral motor problems, poor chewing, and a need for ongoing feeding therapy services. And some of these effects can persist into adolescence and even into adulthood. So how can we get these babies started off right so that feeding is a pleasant experience, eating is a pleasant experience, and they're successful? So both nutrition and how it's provided matter in that outcome. Parenteral nutrition is often the first step. I'll talk about early direct breastfeeding and gavage feeding. I'm not really going to talk about bottle feeding, but of course that's one of the methods of providing nutrition that's often used. So just to talk about parenteral nutrition, it's a necessary bridge for the extremely preterm infant or very sick infant, but extended parenteral nutrition can lead to some life-threatening complications. Oftentimes, central lines are needed in order to provide an adequate level of nutrition. And then cholestasis and liver disease are also associated with long-term parenteral nutrition. So we want to get them past that point as quickly as possible. There are also risks of no enteral nutrition. When I started in taking care of babies back in the early 80s, we would leave babies who were on the ventilator or had umbilical lines in, often with nothing by mouth for 2 weeks or sometimes longer, thinking that if we fed them too early, that would increase the risk of necrotizing enterocolitis. But while we don't know a lot about what causes NEC, we know that not feeding babies actually increases the risk of NEC. You have a gut that you're not asking to do anything. You have decreased blood flow then to that area, lack of perfusion to digest adequately, and now all of a sudden you begin to feed, and those areas of the gut that have been dormant will allow for bacterial overgrowth and maybe lead on to necrotizing enterocolitis. So the recommendation now is to begin enteral feedings fairly early, sometimes even on tiny babies as early as 1 to 3 days of life, but certainly by the 2nd to 3rd day of life that they're getting something to eat. The other thing that we've discovered over the years is that feeding things like water or half-strength formula or breast milk, which we used to do, is not adequate, that they need the nutrition of the milk, and in its full strength is actually more beneficial for the gut and also provides nutrition. So I'll talk just a little bit about early direct breastfeeding because there are several advantages to that, not only getting the milk, but getting it actually from the breast. So this was a systematic review and retrospective chart review that was published in 2015, looking at when is it safe to initiate breastfeeding in infants that are less than 32 weeks post-conceptual age who are already receiving feedings. What they found is that, first of all, skin-to-skin contact is crucial for successful direct breastfeeding. And what many are doing now clinically is babies get skin-to-skin holding, skin-to-skin care at whatever frequency and amount parents are able to provide. And in the meantime, while they're skin-to-skin, if they tend to nuzzle the breast or suckle a little bit, they may not get any milk very early on, but it helps prime them, and it also helps moms keep up their milk supply. So those things are beneficial long-term, and I'll show some more studies in a little bit about that. But this group also found that physiologic stability, things like maintaining temperature, respirations, heart rate, could be maintained as early as 27 to 28 weeks gestation when babies are being fed directly at the bottle, or I mean at the breast. There was less oxygen desaturation, apnea, and bradycardia than if they were bottle fed at that point in time. And some infants exposed to breastfeeding before 30 weeks were successfully feeding directly at the breast by 33 weeks. So much earlier than many people have traditionally done that. You know, we tend to think that babies really aren't ready to do any kind of oral feeding until around 32 weeks, when theoretically the suck, swallow, breathe should be coordinated, but we also know that it's not necessarily coordinated at 32 weeks. So another study showed looking at what we can do to really extend breastfeeding. They looked at, this group looked at breastfeeding until discharge and found that if the baby was receiving breast milk feeds at discharge, it was positively associated with whether the infant was ever put to breast and the number of times the infant was put directly to breast. There was no association with gestational age at first feed. And then some other things that were associated with the duration, the overall duration of breastfeeding, were the number of times the baby was put directly to breast, the first oral sucking feeding being at the breast, and gestational age at that first direct breastfeeding. There's another study that showed looking at the use of donor milk, but they reported that only about 30% of mothers are able to provide their own breast milk to their infant throughout the entire NICU course. And we know that the nutrition in mother's own milk is tailored to her baby and is more appropriate at each feeding at each gestational age than donor milk. And so whatever we can do to support the provision of that milk is going to be beneficial over the use of donor milk. And this group looked at infants less than 32 weeks or less than 1,500 grams. And by looking at chart reviews, there were only 46 babies in the study, but they found a relationship between direct breastfeeding in the NICU and continued breastfeeding after discharge. We know that the more support we can give moms for this, the better off they're going to be. And when they're in the NICU, where the support is available, is no better time to give it. But they found that those who continued breastfeeding at 1 month post-discharge were more likely to have provided 1 or more direct breastfeeds per day in the NICU and had prior breastfeeding experience. And for those who continued for 4 months, that was associated with those direct breastfeedings in the NICU. This group did a systematic review and meta-analysis of quality improvement projects to look at the effect on breastfeeding maintenance, and found that based on the 13 studies that they included in their systematic review, that quality improvement was effective in supporting breastfeeding and continued breastfeeding. And some of the measures that were found across the projects was prenatal human milk education, first milk expression within 6 hours, again, any skin-to-skin time in the first month, the number of oropharyngeal therapy doses within the first 7 days of life, so using mother's own milk for oral care and things like that actually improved the long-term use of breast milk. The proportion of donor human milk fed, so the less donor human milk was fed and the more mother's own milk promoted the continued breastfeeding. Time to first mother's own milk feeding, the proportion of mother's own milk at the initiation of feeds, and the use of a hospital grade pump. So one of the things that sort of limits direct breastfeeding in some babies is this development of sucking competency. This group looked at, again, retrospective chart review of 735 babies born less than 37 weeks gestation, so not very preterm, but found that those with a gestational age less than 28 weeks had the longest time to transition to full oral feeds. But regardless of gestational age, what made the most difference in that time to transition to full oral feeds was increased medical morbidity. And they summarized that the degree of medical morbidity may have a greater impact on time to transition to full oral feeds than gestational age. One thing that we've seen a lot of is that babies with substance withdrawal often have a hard time getting to full oral feeds regardless of their gestational age as well. So just to think for a minute about the development of sucking capacity, it's a complex neurologic and muscle maturation that's required for that to happen. It's more than just sucking. I know oftentimes nurses will think that if the baby has a good non-nutritive suck that they're ready to start feeding, but once they get that bolus in their mouth, they have to coordinate the swallow, their control of breathing, and esophageal function, which may take much longer to coordinate all of that together. So, and again, there's a wide variation of when that's mature, irrespective of gestational or post-gestational age. There are folks working on tools that can help us identify babies with problems. I'll talk a little bit later about those who have trouble, and if we keep feeding them orally, that creates a negative experience, and it may actually prolong the time to full oral feeds. So necessarily, there are some babies that need a bridge to full oral feeds, hopefully at the breast, but regardless of how it's offered, that they can't really coordinate and maintain a good suck, swallow, breathe. So we use gavage feedings oftentimes as the beginning, or maybe some time at the breast supplemented with gavage feedings to promote the nutrition and make sure babies get adequate nutrition. So use of the gavage feeding is one of the most common procedures in the NICU. It's an important bridge in providing enteral nutrition for sick and premature infants so that they're guts get some nutrition and save their livers from the effects of the parenteral nutrition. It helps establish that early nutrition and is a bridge in providing human milk when direct breastfeeding is insufficient. The baby's just not able to get enough in that manner. So just a little bit about actual nutrient levels. This was a study where they looked at the macronutrient concentration in human milk samples. They had 245 human milk samples in this study. And I'm sure it's not a surprise to most of you that there was a wide variation in that. So if you look at the, whoops, sorry about that. The energy or calories in the feeding, we have a wide range of 51.6 to 88.7. So if you calculate that not per 100 mils, but per ounce, as we're used to thinking of it, this mean is a 20 calorie per ounce concentration, but the variation is actually anywhere between 15 and almost 27 calories per ounce. So that's unpredictable. There are folks working on ways to analyze the macronutrients in the milk at the bedside so that the milk can be fortified, or you can take a whole 24 hours worth of milk from one woman, and by mixing that you get a more consistent nutrition, because it does vary by time of day and day to day actually in most women. So the protein level is quite low in these samples that they evaluated. It's recommended that babies get 4 to 4.5 grams of protein when they're fed enterally, and it's very difficult to get that much nutrition even with fortification. But they found in this study that the weight gain for babies averaged about 14.1 grams per kilo per day, and the velocity of weight gain was dependent on the amount of protein in the milk, almost more so than calories. So for each gram of additional protein, that increased the weight gain by about 3 grams per kilo per day. The other thing to note is that donor milk is usually lower in protein than mother's own milk of preterm infants, because donor milk is usually donated by women who've given birth at term. And therefore the protein is such that a term infant would need, and not these preterm infants. And the milk from this study was the mean gestational age of the babies at the time the milk was provided was around 29 to 30 weeks gestation. So one of the reasons I mention that is because when we give feedings by gavage, we do lose some of the nutrient in those tube feedings. This was discovered as early as 1978. Of course, the tubes were different then than some of the tubes that we have now, but this Brooke and other researchers showed a 24% fat loss using tube feeding. Some of that could be recovered by washing the tube, but that has never been a standard practice to wash the tube out to give the baby that extra fat. Other researchers, including Brooks, have looked at things that might affect the amount of fat loss, and one is the syringe position, although in that paper published in 1984, angling the syringe the way we often do it in clinical practice at a 30-degree angle is not sufficient. It made no difference in fat loss. What they recommended is putting the syringe perpendicular so that the fat came right up to the top. Also, the amount of surface area that the feeding is exposed to, so the tubing diameter, the length of the tubing, the amount of time the feed is exposed to the tubing, all of those things made a difference in the amount of fat loss. Some others also looked at other types of nutrient loss. As recently as 2009, 2010, these two studies showed a loss of macronutrients, more so in continuous feeds as compared to gravity or 30-minute feedings. Again, the amount of time that it's exposed to the tubing and the syringe. But they found a significant loss of calcium and fat, and calcium is very important for nutrition and growth as well. And in this study, the continuous feeds showed fat loss as high as 50%. And in the study published in 2009, they looked at triglycerides and carotenoids. And carotenoids are important for the prevention of cancer and cardiovascular disease in adults. But now we're finding out that it's also important in neonates in preventing chronic lung disease. So something that one of those micronutrients that we don't always think about, but may be important in the eventual outcome of these babies. This group also found more loss in babies that were in the milk that was exposed to phototherapy. So they were unsure if that was all due to the fact that it was adhering to the tubing or perhaps peroxidation because it was exposed to the phototherapy light. So that's one complication of gavage feedings that we need to consider, and another is tubing misconnection. That was first reported in the literature in 1972. Reports can be submitted to the FDA, the ISMP, the USP, which is the United States Pharmacopoeia, and ECRI, which is a nonprofit organization that collects and studies medical device malfunction or quality. Interestingly, that first report in the literature in 1972 was in a neonate, and it was a feeding that was connected to IV tubing, and the baby did not survive in that case. The Joint Commission issued a sentinel event alert. Of course, these reports eventually make their way to the Joint Commission in most cases, and based on reports that had come in, they issued the sentinel event alert in 2006 about tubing misconnections. And a sentinel event is any unanticipated event in a healthcare setting that results in death or serious physical or psychological injury to a patient not related to the natural course of a patient's illness. And I'll talk a little bit more about the frequency of these. They don't happen that often, but because they are so high risk, the sentinel event alert was issued. So some of the risk factors, I'm sure you've all seen this, the human factors, we're in a hurry, trying to get the feeding connected while we run to another bed where the alarms are going off or whatever might be happening. Fatigue, attempts to use short-term recall for large amounts of information, which doesn't apply as much with tubing misconnection, but still inadequate training, lighting, or handoff communication. You know, some of the tubing misconnections that I've heard about are things where somebody finds the tube not connected in the bed and quickly just connect it to whatever is close by, not really tracing it back to find out what the connection should be, and again, not the handoff communication, not taking care of the patient for the full shift to know what that is. And also modifying tubing and connectors, and that's something that we've done in the neonatal environment for years because there weren't devices or equipment that was appropriate in size, and so we kind of modified things, and more we have the appropriate equipment, and we need to be using the appropriate equipment because there's a safety factor in that. And then some system factors: using the same tubing for more than one purpose, tubes and catheters used for unintended purposes, multiple ports with similar access points, and then accidental or unintentional disconnections and reconnections. So I've seen and heard of all of those happening, and sometimes it gets reconnected and everything's fine, and sometimes it's not. So just things that can happen in the background that make it a higher risk that it would not be done correctly. So just to talk for a minute about the consequences of tubing misconnections, this was reported in 2006. So the first report that came out in 72, and now here we are in 2006. And this was a premature male infant accidentally given 10 ml of express breast milk IV over a 3.5-hour period. Having survived this event with supportive care, this boy was attending regular school with no obvious neurologic or learning difficulties at 6 years of age. Quite remarkable, really. But in 1998, this group did a query on an email discussion group of healthcare providers in neonatology, and were informed of 8 similar events that proved fatal in 3 infants. So again, numbers fairly small, but it only takes one. So this is from the Joint Commission position paper. The survey was done by ASPEN, which is the Association, the American Society of Parenteral and Enteral Nutrition. Between January of 2000 and December of 2006, there were 24 reported incidents, and 8 of them resulted in permanent injury, life-threatening situation, and/or death. So a pretty high percentage when you think about it, that 33% had that outcome. And then the survey, 15.9, almost 16% reported their institution had experienced an enteral misconnection, and just over 26% reported that they didn't know. So there certainly could be a number of misconnections that are not reported, that we don't hear about or see. So all the more important to address this issue. And so the NFIT tubing connection was created by an organization that brought together manufacturers to come up with a unique design for only enteral tubing. And this is actually the first of an effort of redesigning tubing tips so that they don't fit across purposes. For instance, there's one report of an IV that was connected to a blood pressure machine. So you can imagine the horrible consequences that had. So it's not just the feeding tubes, but everything that we connect that needs to have dedicated sorts of connections. So with the NFIT tubing connection, many of you have probably seen this already, but the syringes have a female connector and the tubing has a male connector. So you can see the syringe there on the left and the tubing on the right that it's being connected to. So in spite of this design change, the Joint Commission, so in 2006, they really started planning that. It was available sometime after that. I'm not sure of the exact date, but in 2014, the Joint Commission came out with recommendations about how do you manage risk while you transition over, because we know anytime there's a huge change in practice, like something of this magnitude, that we have to address that change and how we manage the change in order to not create more risk. So careful planning, proper education of staff, and still maintaining those processes and procedures that will help decrease risk. Tracing the tubing from the patient to the point of origin, high reliability practices like peer checking and coaching, routing lines for different purposes in different directions, and that should be standardized. Label tubing at both distal and proximal ends, and use tubing and related equipment only as intended. So in spite of that change, there are some concerns, as could be expected, about the use of the new NFIT connector. The main one for the neonatal and even pediatric space is the accuracy of enteral medication dosing. So the standard acceptable range of accuracy for most enteral medications is 10%, and for some high-risk medications is 5%. So if you look at the port on this syringe, you can see it's quite a large hub, and so there's a lot more dead space in this port than in our traditional syringes. So a low dose syringe was created, and you can see that on the other side here with a much smaller tip. And that was a topic of discussion, again, went back to the manufacturers group to really address this clinical challenge, and knowing that this acceptable range of error in measuring enteral doses was about 10%, but it's 10% plus or minus 10% accuracy for a 0.2 mil dose. And we know for some of our babies, doses can be much smaller than 0.2 mil. So just looking at that accuracy again, even of the low dose tip, can be problematic. And this group, a group of pharmacists, actually evaluated dosing accuracy in the infant low dose syringe and oral slip tip syringe, and found that with the low dose syringe, there was more than a 10% error in almost 27% of cases, whereas the slip tip syringe, it was only about 13% of cases. And for those high risk medications where you want only a 5% error window, that often was exceeded in both types of syringes. So just to think about some options in managing how these oral medications are handled. This is the slip tip syringe, which is still acceptable for oral dosing. And sometimes in making the transition from to the infant tipped syringe, pharmacies are left with slip tip syringes, and then they get delivered to the floor, and now they don't connect to a feeding tube if that is how you're giving the medication, because some of the medications, of course, can be given directly into the mouth or with a little bit of milk in a bottle. But in this case, you could still use the slip tip syringe that would be delivered by the pharmacy, and then you have this little cap, this dose transition that then will connect to the feeding tube, as you see in this picture here. Of course, there is dead space here, and so that has to be cleared with about 0.3 mils of air flush to get all of the medication into the patient. So if the medication is not being given through a feeding tube, this is one option for giving that. You know, again, one of the issues with these tips, if I could just go back for a minute to one of these pictures, if you have this low dose tip or even the other infant tip, it's large and it's very hard and rough on the edges for the baby's mouth. So that can be uncomfortable and even cause some irritation. So this device fits onto the infant syringe and has a longer tube there where you can put it into the mouth and actually put the medication into the mouth with less risk of trauma to the mouth. So another concern that's been raised is the cleanliness of the connection site, because you've got these lips or moats that go together. So you've got the lip on the infant syringe, and then you've got a moat around the feeding syringe or extension tubing if you're connecting to that. And if you have milk around the edge here, then that's going to get into the moat and can really make it quite messy. So there was one study actually published by Lyman. I'll talk about again, well, move on to the next slide here. I have it, but where they evaluated 2 methods of cleaning. And this was really to address the tubing sticking together, because if you get feedings in that area, then they wouldn't be able to get the tubing undone. This was in an adult population. And they found these methods of cleaning effective, but really didn't evaluate for infection. And, you know, one of the complications of feeding tube in general is the contamination of the tube and growth of bacteria in the tubing. So we are concerned about the cleanliness of those connection sites. So these recommendations at the top of this slide really address the cleanliness of the feeding tube in general, and are from the NAN Policies, Procedures, and Competencies manual published in 2018. Just keeping the tube clean when you put it in, flush the tubing after a feeding to clear the milk, maintain a closed system as much as possible, keep the connection positioned away from the patient. And then there are devices that have been used for cleaning that moat area, like Q-tips, toothbrushes, and gauze. And those are generally as effective as devices provided by industry if you feel the need to clean that. But again, the exact method of cleaning it and whether that actually changes the bacterial growth in that area is unknown and needs more study. But some other practices that could be helpful are to, instead of dipping this into the milk, to draw up milk using an enteral straw so that the milk is drawn up here and this remains clean. And then when this is connected to extension tubing and before it's connected to the feeding tube, the milk is not flushed all the way out and dripping out of the extension tubing before it's connected to the OG tube, that there's just a little bit of air left in that connection so that you prevent getting milk around in that moat. So if you prevent it getting contaminated in the first place, that decreases the need for cleaning, and again, more manipulation of those connection sites, or less manipulation is really what we want. So oftentimes, babies stay in the hospital for prolonged periods of time just because they're unable to eat enough by mouth to go home. And that period of time is often difficult on families. You know, mothers, these pictures show moms at the bedside participating in the gavage feeding and in skin-to-skin care, which is great, but not all moms can do that. And even those who can't do it for long periods of time. And now with the pandemic, there are still many places where only one parent can come in at a time. Sibling visitation has been gone now for almost 2 years. So if they have other children at home, it makes it difficult for them to come in. So we all know that there's no place like home for babies. So if we can get them past that point and home where they're with their family, they're in the home environment. There have been studies that show they progress to full oral feeds faster at home. We've all seen babies that are very difficult to feed, but mom can feed them because she's been the consistent person feeding that baby, and she knows their approach and avoidance signs. Certainly breastfeeding progresses in a different manner, and if we can stick with the breastfeeding and babies are not being exposed to distressing practices with feeding, that has been shown to help as well. We do know that breastfeeding rates have dropped in the US over the period of the pandemic. Lots of reasons for that, but one reason that's been given is that there's less opportunity for skin-to-skin contact if parents aren't visiting much, and also less support for breastfeeding in person. So just some things that hopefully we can address in different ways. I have a few studies I want to share with you here in the last few minutes we have together, talking about what happens to these babies after they go home and how best to support them. So this was a group that looked at telehome care. Interestingly, this was before the pandemic. This was published in 2019, but how appropriate that we have this study maybe to guide different practices when things like this happen. So they looked at growth and breastfeeding rates amongst infants being managed in the NICU and by neonatal telehome care. So the NICU population, the 278 retrospective cases were managed in the NICU until they could attain full oral feeds. 96 of them had ongoing gavage feeds and were part of the prospective group and were managed by telehome care. So they were via communication technology. They had 5 nurses that did the telehealth care. 3 of them were lactation consultants. They found no significant difference in exclusive breastfeeding rates. So these babies had and moms had the support that was necessary after discharge to continue breastfeeding and even increase the number of breastfeeds so that babies could get rid of their feeding tubes. And they did have a slightly higher rate of breastfeeding at the time of discharge in very preterm infants in the telehome care group, but it was not statistically significant. So just that these, even though it wasn't in person, because they also did compare in other studies just having home visits for that, but this was not in person, but they were able to provide the support so that breastfeeding continued and these moms got the support that they needed to do that. So the next study was about transitioning from gavage to oral feeding and when should the NG tube be taken out. So a lot of times we find that NG tube left in while the baby is trying to orally feed, which certainly in the NG route is a little less traumatic, but still I always think about as they're swallowing how that tube may tickle the back of their throat, may irritate the back of their throat. And they may not feed as well with the tube in as if we could take that out. So this study really looked at that in what they defined as early versus late removal. So early was defined as infants were taking 60 to 79% of their feeding by mouth for 2 days before, and late was defined as infants taking 80 to 100% for 2 days, and then the tube was removed. So there were similar rates of breastfeeding in the 2 groups, 50 in the early group and 45 in the late group. And they found a trend toward fewer days to full oral target volume in the early group. None in either group required the NG tube to be replaced. And they did a subgroup analysis of babies under 28 weeks, which found the same outcome. So just showing that taking it out maybe a little bit earlier would not be detrimental. And then this study from a level 4 NICU looked at the use of gastrostomy tubes versus home NG feedings. And I know there's a lot that needs to go into whether a baby gets discharged with a nasogastric feeding tube, about what kind of support parents have, the competency of the parents themselves, but they did have a home NG feeding program out of this children's hospital. But some babies nevertheless got gastrostomy tubes. So they had 140 discharged with NG feeds and 124 discharged with gastrostomy tubes. All of them were taking at least half of their feedings orally before they were discharged. And more than 60% of those who had an NG tube in place had attained full oral feedings within 60 days of discharge. and almost 90% in the gastrostomy tube group were still requiring gastrostomy tube feedings at this point. Now, there were some babies in the G-tube group that weren't really expected to progress any faster because of the reason that they got a G-tube, but nevertheless, there were a significant number that were expected to, were already taking half of their feeds by mouth, and they were expected to be able to progress more quickly. So they found that the factors that were associated with the successful oral feeding were a higher percentage of oral feeds at discharge and receiving maternal breast milk at discharge. And this was the case whether they were fed by NG or G-tube. So the other thing to remember that while the G-tube is often a big deal for parents, and we understand why that is, because it's a surgical procedure, it's often seen as a more permanent fixture than an NG tube, but the NG tube could lead to more oral aversion and prolonged feeding difficulties as well. So that has to be considered too. So some of the things that serve to hinder or promote the development of feeding skills when we talk about how we can help these babies really get to the point where they're successfully feeding and it's a positive, enjoyable experience. Focusing on volume as intake, that, we have to get X amount of volume into this baby, no matter how we do it. And oftentimes it's by pouring it into the baby rather than letting the baby eat it. And repeated stressful experiences that can actually change the brain development and neurodevelopmental outcome if feeding is a stressful experience for the baby. So rather looking at behaviors, only feed when the infant's awake, when they're physiologically stable, they have a good breathing pattern, watch even during the feeding for changes in sucking pattern, their state, feed them when they're awake. Don't push the nipple in and out. If they're pushing the nipple out, then that's a sign that they're done, or just clamping on the nipple, or stop sucking altogether. So observe the baby's swallowing, breathing, physiologic stability, their postural control and state regulation, and modify the feeding approach accordingly. And then that really is the definition of cue-based feeding, that it's driven by quality and not quantity. Emphasize infant eating versus feeding, and feeding should be relationship driven. I used to work with an occupational therapist whose work was really in helping feed babies and figure out what worked for them and what didn't. And she said it's the biggest job that these babies have, that parents would ask, well, you're an occupational therapist, the baby's not working. Well, they are working. They're working at developing the proper skills so that they can feed successfully and have a pleasant experience doing it. And how can we help them do that? So again, the mother-infant bond, if babies can be with their mother in the home environment, it's been shown to lead to faster full oral feeds. So if we need to promote that in the NICU, just thinking about how we can do that as well. So I just put my contact information up there. You'll be getting the slides if you haven't already when you registered. So if you have any questions that don't get answered, but we do have a few minutes for questions. So I'd be happy to take any questions you have.
Thank you, Sandy, for that great information. We do have about 7 minutes for questions. So if you would like to submit your questions through the chat function, we can try to get to those. I also just deployed the link for the evaluation. If you need nursing contact hours, we'd love to have you fill out the evaluation form on this, and we can send those out Friday for you, everyone that's on the call. And I'm just waiting to see. There was one question that came in the chat, and this is more of a Medela question, Sandy, but this person is asking if it is safe to use Medela pump wipes on the enteral tubes. And if you don't know that, I have to research that a little bit, but I'm happy to get that answer. What are your cleaning practices in your facility, Sandy?
We just clean them with sterile water and Q-tips primarily.
Okay.
So I don't know, that may be okay, but I'm not familiar with what's on those wipes, so maybe you can research that.
Yeah, I will definitely find out. And someone is asking how to get their certificate. The attendance for today will be taken later today, possibly tomorrow morning, and then everyone will be able to log into your account to download your certificate. Someone is asking where if they can get the slides. If you can email education@medela.com, they were sent out around 11:20 a.m. Central Time today to everyone. So check your spam or junk folder. They may have ended up there because they did come from the education email. But if you want them to be sent again, I can certainly send those out to everyone. People are saying thank you for your information. A question that just came in asking, can you PO feed while doing gravity?
Theoretically, yes. So you have the feeding tube in, and you're giving feeding in that plus your PO feeding at the same time. Yeah, you could do that if you're coordinated enough. I don't think I've ever seen that, but certainly we non-nutritive sucking with gavage feeds is common and is recommended. So PO feeding with gravity would be no reason you couldn't.
Okay, thank you. The next question that came in is it best to flush the tubing to the baby at the end of the feeding so the baby gets the benefit of the milk in the tubing? Also, do you recommend perpendicular placement of the feeding syringe?
I do recommend perpendicular placement of the feeding syringe. And yes, the practice of flushing the tubing at the end of the feeding is more and more common so that you're not wasting the milk that's in the tubing. So a lot of people do that as well. It's a good idea.
Okay, thank you for that. I don't see any more questions coming in through the chat, so we will go ahead and end today. We've got maybe 3 minutes left. Thank you again for, oh, hold on just a second. Someone just sent in a question. Bear with me. Do you recommend or use a particular breastfeeding score system to help assess feeding effectiveness and determine top up volume?
Well, we use the latch scoring system, and we don't do the top up volume. We usually just let the baby breastfeed, and then if they want more, we'll give them more depending on how much time they've spent at the breast. So I know a lot of places will do they'll either use a scoring system or they'll do the pre and post weight. But as long as the baby's not losing weight, we just do offer them feeding after they get done with the breastfeeding, and top up that way. And if they're not interested, then we don't push it.
Okay. One more quick question that just came in, or actually a statement. Someone was saying we were told we should not be perpendicular if milk is fortified. Do you have a comment to that?
It probably depends on the fortifier that you're using, although the fortifier should be mixed well into the milk. If you're using the liquid fortifier, then it shouldn't matter. And again, the nutrition that you have in the fortifier, you don't want to lose. Actually, in one of those studies, they talked about the difference in the loss of nutrition between powdered and human milk fortifier, and found less nutrition loss with the human milk fortifier. So if you're feeding the baby the entire syringe and your fortifier is mixed in well, it shouldn't separate out like that.
Okay, thank you for answering that last question. It looks like it's top of the hour, so thank you everyone again for joining us today for this webinar, and thank you, Sandy, for presenting this great information. As a reminder, certificates will be available on Friday by logging into your account, and registration is now open for our November 17th webinar. For more information and to register, you can visit medilaeducation.com. And we also have a banner on that page where you can register for the on-demand recordings of our 15th annual symposium that was presented last month. So feel free to register for that. And I hope everyone has a great afternoon. Thanks again.